to the APAPP podcast. I'm Jennifer Weber, pulmonary nurse practitioner and chair of the Asthma Committee at APAPP. Joining me today to discuss SMART and air therapy are two members of our Asthma Committee and incredible APRNs practicing in pulmonary medicine, Stephanie Bork and Melissa Dolbec. To start this conversation, I think it'd be helpful to go back to basics and define asthma before we discuss the rationale behind these therapies. So what is the latest definition of asthma?
GINA and the NAEPP define asthma as a mixed disease, usually associated with chronic inflammation of the airways. This inflammation and associated hyperresponsiveness may result in reduced expiratory airflow that can wax and wane or become fixed over time. Symptoms for asthma can include coughing, wheezing, shortness of breath, and chest tightness. These may vary in intensity over time. This inflammation and hyperresponsiveness can be triggered by exercise, allergies, environmental irritants, changes in the weather, and upper respiratory infections.
Thank you for that refresher, Melissa. And how do we diagnose asthma?
Great question. We want to get a detailed history and physical that may support the diagnosis. Additionally, when we can, we want to catch expiratory airflow obstruction with either spirometry or peak flow variability. And it really is important to try to make the diagnosis as early as possible. People who are untreated or undertreated are at risk for a fixed obstruction over time, secondary to airway remodeling. I think it's really important that we talk about the fact that the GINA 2024 guidelines report 300 million people have asthma. 1,000 of them are dying daily. Many of these are low income or middle income populations. Also, it's important for our listeners to remember that people with mild asthma or people who have minimal symptoms are at risk for severe and fatal exacerbations.
Wow. It's important to realize how many people really have asthma. I think you just said 300 million globally. That's a lot. And the fact that it disproportionately affects low and middle income people, we need to pay attention to these vulnerable patients. So what I'm hearing is that the key in treating asthma is targeting treatable traits, such as airway inflammation. Can you guys speak to how asthma inflammation has played a role in asthma treatment options?
Yes. So targeting airway inflammation really has been the cornerstone of asthma therapy for many years. We know that treating the inflammation is really the most effective way in preventing progression of disease and also airway remodeling. We're going to share an iceberg graphic with you. We use the iceberg graphic a lot for many things. You may have seen this before. But this one really shows how the symptoms are really just the tip of the iceberg. So what we as clinicians see or what patients experience are really just that top piece, but there's a lot more below that tip of the iceberg. And it's really important for us to understand what's going on below the iceberg tip. So at the very bottom, you can see that airway inflammation is really the driver behind airflow obstruction and bronchial hyperresponsiveness. And then eventually that's what leads to symptoms. And sometimes we don't have those symptoms right away that, we may have those things brewing underneath before the symptoms are exhibited as well. So when we think about how to really target that inflammation through therapeutics, the primary mechanism is through corticosteroids. And this is really how we reduce inflammation and therefore treat asthma. There was a time we only had oral corticosteroids. So many of our patients, maybe who have been around a little longer, remember maybe only having the option for oral corticosteroids at one point. But really, we know that oral corticosteroids have a lot of detrimental effects to our health. And so really, we now have been using for several decades inhaled corticosteroids as a mechanism to treat inflammation. And so I always teach students, patients, that these corticosteroids are what help to reduce inflammation, and therefore that's what's going to help treat their disease and eventually reduce their symptoms of asthma. So I know that was a lot of information. So just to summarize a little bit, is that symptoms in asthma are really just the tip of the iceberg. So remember that inflammation is really that underlying driver of symptoms and exacerbations of asthma. Using an inhaled corticosteroid in asthma management really helps to target airway inflammation. And most recently, we've seen a large paradigm shift in asthma management, which includes the use of as-needed inhaled corticosteroid with reliever bronchodilator. And so once we kind of understand that what we're attempting to target, which is really not just hyperresponsiveness and symptoms, but really the driving force is inflammation.
Thank you so much for that great outline on airway inflammation and inhaled corticosteroid use. So, moving on from that traditional treatment model of either oral or daily inhaled corticosteroid use for nearly, well, for inhaled corticosteroids for nearly all asthmatics to the more as needed approaches. What does all of this stuff mean? We have terms like SMART, MART, AIR, PARTICS. It's alphabet soup and it's a little confusing. So, what we had seen in the asthma world is the most primarily prescribed asthma regimen based on the global GINA guidelines is SMART or MART. So, what is MART?
Yeah, so it's a great question to really dive into some of these therapies. It gets really confusing, even for a lot of us pulmonary specialists, I think, over the years, kind of getting all this straightened out. So let's start with SMART or MART therapy, which those are the same thing. They really just stand for the SMART piece is single maintenance and reliever therapy, or you can call it MART. And what this is where you have one inhaler that's acting as both a maintenance and reliever inhaler. So the patient receives one inhaler, and this must be in an ICS formoterol form, for both that maintenance and reliever. It can't, you don't have two different inhalers. It's really just that one ICS formoterol. Other types of long-acting beta agonists like salmeterol or vilanterol are not acceptable. This is because formoterol has a really quick onset of about 45 seconds, similar to a short-acting beta agonist. So it's really important that you're only using formoterol for SMART therapy and you're not using these other LABAs. The only ones that are available to us in the United States currently are budesonide formoterol or mometasone formoterol. So those were what you're going to be looking for if you're utilizing SMART therapy. It's important to remember that this is guideline recommendations from GINA for steps 3 through 5, and it is approved in other countries like Australia, New Zealand, and many European countries, but currently not FDA approved in the United States. And this really can create some barriers to getting enough drug for a true SMART therapy, meaning you have enough puffs to act as both your maintenance and reliever therapy. Because currently all US formulations of ICS formoterol are 120 puffs. So that can be a little difficult. And we'll talk a little bit more about that in a bit. But one last reminder, too, when you're thinking about SMART therapy, is that it's not recommended to use a triple therapy inhaler. So a single triple therapy, which would have ICS, LABA, LAMA, with an ICS formoterol as rescue. That's not currently guideline recommendations.
Thank you so much for clarifying that, Stephanie. And I just want to ask a clarifying question for the whole audience. So, SMART and MART is the same thing. And that means that the patient is using just one inhaler for both maintenance and reliever.
Yes, that's correct. So they get one inhaler and they're using that both as so they get an ICS formoterol, they take that 2 puffs twice a day, and then if they have a symptom that they need a reliever, you'll use that same ICS formoterol inhaler when they need a rescue or reliever dose.
All right. So, what about our patients that are truly using as needed therapy? And what's AIR?
AIR stands for anti-inflammatory reliever therapy. So this is going to be a standalone therapy that's used as needed or in conjunction with a maintenance inhaler. These inhalers are going to be low dose ICS with formoterol or a low dose ICS with a sub. Points that bear repeating, like Stephanie said, non-formoterol lavas cannot be used as relievers. And we're not going to use formoterol with other lavas as a reliever. So what this might look like in practice, if you couldn't get a person's if you couldn't do SMART because you couldn't get enough inhalers covered, you might do a high dose ICS formoterol as the maintenance, and then the low dose would be your reliever. Or if you had someone who was doing an ICS salmeterol, you might do an ICS SABA as the reliever. This is a great time too to point out that GINA and the NAEPP have a little bit different guidelines. GINA advises the ICS formoterol as a reliever for all asthmatics, all severities, where NAEPP advises ICS SABA for step 2 and SMART for steps 3 through 6. There is a brand, ICS SABA, that is approved by the FDA for all asthma severities, all steps. So that might be something to consider depending upon your patient's formulary as well.
All right. Thank you for that explanation of air therapy. I think it's really helpful to understand that air has this umbrella of patients that are using truly just an as needed medication, or they're on their maintenance therapy and using a reliever inhaler with that extra inhaled corticosteroid in it. So that could include a lot of different situations. So it's really important to understand this terminology so we can apply it appropriately. So I want to bring up a third option that some of our patients with barriers to implementing this guideline based care need. So, this is called PARTICS, patient activated reliever triggered ICS. And the way we explain it to patients and want people who don't deal with these types of asthmatics every day to think of is you're taping the reliever to an ICS inhaler. That's because they will be used together, but are actually separate inhalers. So, that is the difference between these other anti inflammatory reliever therapies. So there's this really nice graphic here from an article in Chest by Zay and colleagues that goes through the difference between smart, Partix, and air. So you guys can take a look at that if you have a visual component when you're listening to this podcast, and that just gives you a quick highlight on that. But going back to Partix, so patients with alternative regimens or intolerances. So some examples can include patients on nebulized medications only, those who cannot tolerate albuterol or formoterol. For example, they can only use levalbuterol, or they need a specific ICS formulation. Think antiretroviral therapy. They might need this alternative regimen. So the patient will continue their usual baseline maintenance regimen. And then when they need a reliever, they will take one puff of SABA followed by a puff of ICS. If they're on nebulized formulations for reliever, they can use one nebulized SABA followed by 5 puffs of ICS. So, again, this isn't really yet common practice. There are more studies in progress, so we may be seeing a little bit more data in the coming years. And I do want to highlight that this does meet criteria for step 2 asthmatics under our national asthma guidelines or NAEPP. So, we've reviewed the ways in which patients can use ICS reliever, but we haven't yet talked about the research behind it. So, why is GINA recommending this therapy to all asthmatics throughout the severity spectrum?
Yeah, I think this is a great point to kind of step back and think about why we're really doing this in clinical practice. And it feels like this is, for too many people, this is new. But really thinking about that, this guideline recommendation came in now about 5 years ago from GINA. And there were decades of research kind of before that, more than a decade of research prior to that, that really helped to support that change and this huge, really, really large paradigm shift in our practice. And so, I would highlight that the GINA guidelines do, go into, and we'll put this in the show notes, the link to the GINA guidelines. So if you want to go back and do a little digger or deeper dive into the research, that those are all referenced there that you can go into. But just a quick overview is that really some of the data that came out of the basic science literature talks about excess short acting beta agonists and how these SABAs really would upregulate the beta receptors in the lung, therefore increasing inflammation. So, thinking about, as we talked about, inflammation is the driving force behind asthma, we're now giving a therapy that is actually increasing inflammation, which is problematic, right? What we further learned is that patients that use ICS formoterol or an ICS with a SABA, so in combination, that there was improved levels of control. So this was less likely, that use of those inhalers was more likely to prevent an exacerbation or ER visit than SABA use alone. We also know that patients who use ICS in combination with formoterol or SABA, that they have higher symptom control scores. So the ACT or ACQ scores are higher in those patients. We also know that especially in patients who use as needed, so like air therapy, that there is less ICS use overall compared to a daily ICS and albuterol. And so when on average, those milder patients are using this maybe three to 4 times per week versus a daily ICS. So, the evidence is really strong that all patients use ICS formoterol or ICS albuterol or SABA as reliever, but let's be real that this change has been hard, even in the pulmonary providers. I think now we've seen this shift that pulmonary specialists and asthma specialists are using pretty regularly now for the last few years. Um, but it's been hard to get everybody on board. Even our national guidelines, as you mentioned, Jen, the NAEPP does recommend ICS formoterol now, which is a smart therapy for step 3 and above. But still, step 1 really just advises SABA alone, and step 2 is really ICS plus SABA. So, I think it's just been tough to get a lot of the US providers, partly probably because our guidelines are a little bit outdated, but to kind of get everybody on board. And also, this paradigm shift really goes against about 30 years of telling our patients, right? How many times have we told our patients, like, this is your maintenance, this is your reliever, don't get confused, like, let's keep them separate. And now we're trying to switch all that up on everybody, right? So it really is confusing. We know, I mean, we probably all have had these conversations on a daily basis with our patients about how confusing it is to explain this to them, and help educate the patients. But we really need to take the time to educate ourselves, other clinicians, and our patients on why this is important to make that shift.
You did a great job discussing how us asthma specialists have seen this paradigm shift play out, hesitance on both the patient and provider side, within and external to pulmonary medicine. This is a really difficult change to make in asthma management. So, all of us practicing in pulmonary medicine really need to advocate for guidelines based care whenever we can. So, we've kind of touched on these points, but very briefly, once the FDA gets on board with the way that these traditional controller inhalers are being used as relievers in many other countries in Europe, Australia, etc., then I think it'll be a little bit easier to implement these guidelines fully. So I do want to point out too that the research isn't new. So if you take a look at this graphic, if you're able to take a look at it, GINA's first report came out in 1995. So that's when the global initiative for asthma started giving us more concrete asthma management guidelines for our patients. And then about 10 years later, that's when the MART studies began. So since 2006, GINA has been recommending that MART be implemented in step 3 and above patients. So this isn't really a new concept. In 2014, there was another change as GINA began to then question the need for daily ICS in step 1 patients, or what we refer to as our mild intermittent asthmatic. And then in 2019, there was a formal recommendation to discontinue SABA only therapy, like universally, and transition to anti inflammatory reliever therapy or AIR in step 1 and 2 patients, and then MART or SMART in 3 and above. So, in other words, from 2019 on, the shift to using ICS with reliever therapies has been advised for all asthmatics. So it's 6 years later now, and there's still confusion and hesitancy regarding the changes to these guidelines. So, Stephanie and Melissa, I would love to hear about your experience on the front line as asthma specialists regarding switching patients' therapies based on these guidelines.
Yeah, so we like to maybe walk through a few examples with you all just to kind of make it a little bit more real of some of the things that we face on a pretty regular basis and really over the last several years with these changes. So, one kind of example we'd like to give is if you consider a stable 85-year-old woman who is on low dose daily ICS, been maintained on this therapy for many, many years, very comfortable with how to use it, been doing it every day, consistent, never misses a dose, always picks up their refills, that type of thing. And has not needed prednisone in several years and uses albuterol very infrequently, so less than every 2 months. How would you approach this patient? So, thinking about, if we're going with guidelines based care, this patient most likely can be stepped down to an as needed anti inflammatory and reliever therapy. They may not really need a daily ICS given they're well controlled for many years and not at high risk for exacerbation at this rate, or with this data. So really the pros would be we switch to a guideline-based care, we consider AIR, and this would really potentially be less expensive because they may just have the one inhaler and they wouldn't have two inhalers to fill, and using less of that inhaler overall and probably having less exposure to inhaled corticosteroid. The potential downsides or kind of cons of switching is that it may be confusing for the patient. Again, we see a lot of patients who are very kind of set in what they like to use, comfortable with the device. We know there's many devices, so that might be hard if they're switching to one device to another. There may be a possibility of increased asthma symptoms when initially decreasing, from a daily ICS to an as needed. Um, and there may be provider hesitance, not just the prescribing provider. There may be some, but also other providers that they see. So they're going to see other people or clinicians, and they're questioning why they're being switched or why they're on this therapy. And then lastly, really the possibility of insurance barriers. This is a big one, right? One that we face every single day of switching people on and off different inhalers because of insurance coverage. And so that's always a big barrier potentially if this would be covered. But I think ultimately it's really important to consider that every patient may be individual. And so, really talking through that with each of your patients, educating and expressing, why you might be wanting to switch and understanding the patient's willingness to switch therapy. And that it may take more than one time to really go over this and educate and discuss with your patient to be successful in that change. Melissa, I think that you also had another example that you wanted to highlight and share.
Yeah, I do have a case I'd like to share. So this patient, after not returning to our clinic for several years, came back to us recently on a high dose ICS salmeterol, going through 4 albuterol inhalers a month. So clearly, we needed to do something different for her. And so, as opposed to adding a llama to what she was doing, um, the decision was made to go with a high dose ICS formoterol as the maintenance and the reliever. And so we'll see her back in a month, and hopefully, it might not be perfect, but there will be a increased reporting of less symptoms and decreased use of the reliever. So for this patient, the pro would be again the evidence. People who use ICS formoterol or ICS saba as a reliever have better symptom control, less utilization of the ED, and fewer exacerbations. Some cons for this patient specifically, she is at high risk for overusing her bronchodilator. So, at that first visit with her, when we're changing her inhalers, we spent a lot of time with her talking to her about when to call us back. So, if she's using more than 2 puffs twice a day of her reliever, in addition to her maintenance, 2 days in a row, we want to hear from her. Um, and really, she shouldn't be using or exceeding 12 puffs in a day. And so there is that concern with her. The other thing is this is someone who clearly really likes the benefit of albuterol. And so when we see her back, if she is not happy with the ICS formoterol as the reliever, we'll have a discussion with her about doing ICS SABA instead. As we've touched upon, but again, bears repeating, um, is she going to have a problem with her insurance? We need to make sure she's going to get enough inhalers. And again, saying that other providers who are not familiar with the guidelines coming in contact with that prescription and being like, oh my gosh, what is going on here? So, one thing to consider is writing on the prescription SMART or AIR or GINA 2024 so that people know that this is guidelines based therapy. When we see her back, if she wants to go back, or sorry, if she wants to go to an ICS SABA, or she is overusing her maintenance ICS formoterol, then we will just switch her to a different therapy. As passionate as we are about this topic today, we do want to remember SMART is not for everyone.
Absolutely. I also want to just quickly mention where this 12 pups per day max dose came from, because we may be speaking to an international audience here with different formulations than we're used to here in the US. So for us, the common dose with formoterol inhalers is usually, like for example, budesonide 80 micrograms and then 4.5 micrograms of formoterol. So that's where the 12 puffs per day comes from, as the max safe dose is 72 micrograms per day. So that may be different depending on what country you're in when you're educating your patients on their maximum puffs per day. But again, the max safe dose of formoterol is 72 micrograms a day. All right. So we educated our patient and prescribed MART or air therapy. Now what? Does it get covered by insurance? And how do we overcome these barriers?
Yeah, thanks, Jen. That's a great point, and definitely, I think it's we touched on it just a little bit. We're going to go into a little bit more detail because this is a huge barrier. And again, just a caveat that obviously this is dependent on your location, usually state by state, depending on formularies, and coverage based on different insurers. But we're talking mostly in the United States. A lot of these barriers too, because of the way they are formulated by the FDA here. In our country. So, with current formulations for MART or SMART therapy, you like mentioned before, you need to have at least two inhalers of 120 puffs. If you are doing full maintenance therapy of 2 puffs twice a day, that patient will run out because they're getting 120 puffs just with their maintenance dose. So they won't have enough for reliever dose if they need a reliever. So you really need to be prescribing two inhalers if you're doing true SMART or MART therapy. There are 4 available options. So one thing is to look and see if you can figure out what's covered by that patient's formulary. And we do have one that's now more of a generic option with budesonide formoterol that tends to be covered quite well in my experience. One option is sometimes if you can't get 2 of the same, I've seen also doing a high dose and low dose ICS for formoterol as a backup. So you maybe give the high dose as their maintenance and then the low dose as their reliever. Or you can think about doing more kind of like a combination where they have a maintenance and then just using air therapy as their reliever. So you would do a budesonide albuterol as a reliever. So that's an option as well. A few things about coupons and costs. We do now have the $35 federal price cap for AstraZeneca products. So if you have an AstraZeneca brand, you can ask pharmacists to use that coupon. However, remember that's only for commercially insured patients. That does not help your uninsured or your federally qualified patients like Medicaid or Medicare, which is frustrating because those tend to be the ones that we need more help with sometimes. Sometimes you may be able to look for coupons for commercially insured. GoodRx really, in my experience, has not been great for ICS formoterol formulations, but you can always check that. It's always changing. So some other coupon options. And then lastly, Canadian pharmacies, if you have any patients that order through Canadian pharmacies, there is a budesonide formoterol that's about $60 for 360 doses. So then you can do true smart with only one inhaler.
All right. So, another challenge that we've seen is now we've put a patient on our guidelines based therapy, we've supported them in making that change. They're going about their life, managing their asthma, but then they encounter another provider, be it a primary care provider, emergency room, whatnot. And that provider may get a little concerned and think that's too much LABA exposure or that we're prescribing something that's off label. So, what are we supposed to do as the asthma specialist or pulmonary provider if another provider discourages this therapy in our patients?
Yeah, unfortunately, that is common across the nation with different providers. So we want to educate them when we have the opportunity. One thought is really stressing to the patients that we are responsible for their inhalers. So if someone is encouraging them to change or questioning the therapy, we can have conversations with those providers of, and teaching them and updating them about the guidelines. Why is it that we chose this plan of care? Clearly documenting on the prescription. Again, we want to make sure anybody who's coming in contact can see that we're following guidelines. Right SMART, right AIR, right GINA 2024. And it potentially is an opportunity for them to learn about the guidelines at that point as well.
Fantastic idea. That really helps, I think, with clarity on all ends. So, what about our patients that are under perceivers? Or they just don't really notice their asthma symptoms or don't tell us about their asthma symptoms as much as we would like. And we decrease this patient from a daily ICS to an anti inflammatory reliever therapy approach. In your experience, has this destabilized someone's asthma?
Yeah, I think this is a great example, and I'd be curious if some of our listeners have come across this too, because I see this less now, I think, than we used to. But there has been concern, even amongst providers, to decrease or kind of step down these patients' therapy of patients they think are kind of these what we call under perceivers. So just thinking about that, those would be really I think generally a subset of patients that we understand where they are not recognizing their symptoms of their asthma until it becomes very severe. And so there's concern that if we step down their therapy, that they won't know, and then they'll kind of destabilize quickly. I definitely think, obviously, as we said before, this every case is an individual basis. So you have to think about your patient and decide if this is the right therapy for them. But I think we can feel empowered to be okay with using air and smart therapy. But I always recommend in some of these cases using more objective measurements with these patients. So it's really helpful when you step down to use things like spirometry, pheno, and even peak flow monitoring at home to monitor, or Spiro at home if you have that availability, because we have that now, to really monitor these patients on therapy then a little more closely. And doing a close follow up. And so, for example, if you have somebody you bring in, you decide to step them down to air therapy, you switch them from their traditional maintenance, then maybe you have them come back in 2 to 3 months and repeat a spirometry, and then educate them on using home peak flow monitoring in between, and letting I tell my patients, message me in the portal, let me know how your peak flows are doing. They send me updates, and then we can adjust as needed. And if objective measures stay stable, great, continue on air therapy. But if their numbers worsen, then maybe you talk about whether maybe this person might be more appropriate for technically more of like a step 3 where they'd be on maintenance therapy. And so it's important that also to think about, you could try a taper option where, maybe they taper down to a more regular dose a few times per week for the first week or two, to help kind of keep symptoms controlled, and then slowly decrease to as needed. And I've certainly done that as well in the past. So those are some things to think about, but definitely feel empowered to talk with your patient, work with your patient, and get them on this, because I think the benefits are definitely there for these patients.
You are on to something. I think with the taper, all of us practicing in the pulmonary realm, we love a taper. We know taper. We do it all the time with our oral glucocorticoids. Our patients know what that is. So that concept of kind of tapering off that daily dosing until they're comfortable with their new like air therapy, I love that. I'm gonna start doing that.
I think patients feel better about it too. They're like, "Okay, it's not such a hard change. I can taper off, and then I can get on the as needed." So sometimes you can win them over that way as well.
Yeah, love it. All right. So to round out our talk today, we've talked so much about what we need to do as the provider, advocating amongst, healthcare providers in general, understanding these guidelines, but we haven't talked so much about what we need to do for our patient. So last, certainly not least, Melissa, how have you empowered your patients on the paradigm shift?
Lots of education, reminding patients that we are partners in their healthcare, encouraging them to look at the guidelines. I try to talk to them about the ICS, the inflammation, the formoterol, the mechanism of action, um, and explaining to them the possibility that, hopefully over time we're going to use less medication as we go. Um, Once we've provided education to them, making sure they have access to it. I try to do a really detailed ABS, remind them that they can see the medical record themselves. They can see my notes. They can see the plan of care. Oh, for some people, if I want to reiterate, I might also just send them a My Health message, or that's what we use is My Health. Um, Asthma action plans sometimes we'll do, and then really bringing them back so we can reassess, where are they with their health literacy on this. So we might do RN visits. I might see them back every 2 to 3 months, sometimes for up to a year, just to make sure that they can articulate the plan of care, so that if they're questioned about it or if they have concerns about it, they're comfortable, and then really empowering them to reach out to the clinic in whatever ways they're comfortable with. Phone calls, my chart messages, just trying to keep an open dialogue with them until they're really comfortable with the plan.
Yeah, that's really some really great points. I think it's so important that we're educating the patients, and not, just patients, but definitely as asthma specialists, we want to educate everyone. So patients, pulmonary providers, and eventually our PCPs. Even think about, don't forget urgent cares and emergency
Big
rooms,
one.
because our patients land in so many different places within the healthcare system. And so it's really important we're educating all of those different touch points where our patients are finding themselves. And asthma, because it affects so many people, it's really a huge opportunity for us to prevent poor outcomes for these patients in our communities. So advocate whenever you can. Lecture at your clinic, to your APP team, students, medical learners, community groups. I've done community groups talk like American Lung Association, things of that nature. Your hospital group, really wherever you can. It's really going to help us elevate the care of these patients at the end of the day. So just keep that in mind. Share this information. Take it, read the guidelines, and take it where you can.
Melissa and Stephanie, thank you so much for talking about all of these therapies in detail with me today. And to our listeners, thank you for joining us for the Asthma Committee's edition of the APAPP podcast. If you're interested in becoming a member of the Asthma Committee, email info@palmapp.com and we'll get you connected. Don't forget to claim your CME for this episode by clicking the link in the notes. Please support APAPP by hitting like, share, and subscribe to the podcast. Have a great day, everyone.